The next talk will be given by Dr. Fozia Siddiqui before lunch. After that, we will be heading towards lunch. Dr. Fozia Siddiqui is consultant neurologist and epilepsy expert at Aachen University Hospital.
So I'm going to, it's 15 minutes, I'll try and wrap up in 12 minutes. And that's really not very easy, especially, as I say, that women should have a little more time and they tend to job more than females. And see, I've already wasted half a minute on that. Okay, so epilepsy in Pakistan, the care and training, what we do. So basically, epilepsy, defined by the International League Against Epilepsy, is a person's considered to have epilepsy if they have 2 or more seizures, they have a tendency towards recurrent seizures, or if they've had even 1 seizure, but it's unprovoked. And but the probability of having a second seizure is very high. So, and obviously, if there's a diagnosis of an epilepsy syndrome. So, in Pakistan, what is the patient's perspective? So, I did a study and I gave for 3 months, all the patients with epilepsy that came into my clinic, I gave them a little, I just asked them to write something about epilepsy. And one I'm going to share, there were quite a few interesting ones, most of them were very depressing, but this kind of gives you exactly what majority of the patients feel. That it's an enigma, it's a paranoia. There's a lot of ignorance around this disease, and the person suffering from this disease is lonely, is unbound, and because of persistent seizures. And the million-dollar question, why me? Which is exactly what this patient of mine was asking when she got married, had an epileptic seizure, was 5 months pregnant, was forced into an abortion and divorced and left home. So this is ignorance at its peak when it comes to this disease, because the big myth that this is a demonic possession is very, very much prevalent in Pakistan, especially in the rural areas. The cities over, and so this is what got me to start epilepsy awareness programs. And when we did these 5 years ago, we had some statistics that I'll show you, and this year again we're going to do and see what the awareness has brought. But it seems every year we seem to be having better awareness and more patients believing that this is actually a disease. Before, when you give the diagnosis of epilepsy, though, there was neurological, there's stroke and all of that. But epilepsy, it's as if they're gazing at death. And they're wrapped up in a shell. The worldwide epidemiology, as you can see, that it still remains one of the commonest chronic neurological disorders. And the prevalence, lifetime prevalence is about 9%. And 0.1 to 1%, where Pakistan is on the 1% range where it comes to prevalence. And according to the WHO recent statistics, about 50 million people suffer from epilepsy. And in Pakistan, if you take the 1% of the general population of 20 crore, then it would be about 2 million, which would be 1/10 of the entire world's burden of epilepsy lies within Pakistan. So when we did our survey, we saw that higher prevalence was in the age of less than 30, higher prevalence was in the rural population. Idiopathic epilepsy was 21 to 76, but then we did not have the means to do a proper diagnosis. This was based on a history performer questionnaire. But the interesting thing was that only 27.5% of epileptics in urban areas and 1.9% in rural areas were treated with anti-epileptic agents. Just before we go on, especially in epilepsy, these factors really count a lot. The gross national income, as you can see, compared to developed countries in Pakistan, it's way, way below what they would even call the poverty line. And access to healthcare is very limited. Healthcare funding, it's barely available. Cultural perception, the traditional medicine and spiritual approach still prevails. And Common epilepsy etiologies, idiopathic, neoplastic and cerebrovascular is what you see in the developed countries. But here we see post-infectious, antenatal, post-traumatic more than we see idiopathic, neoplastic, which again are now on the rise. The cultural attitudes. There's an overt negative public perception and stigmatization and discrimination which is very common here. The treatment gap in developed countries is less than 20. But in the developing countries, it's 80 to 94%, and Pakistan has about an 85% treatment gap. Many different seizure semiologies and diagnostic facilities that we have, EEGs are present, but the quality and reporting is substandard due to lack of qualified neurophysiologists. People who can actually differentiate between artifactual sharp waves and actual sharp waves, between an artifactual electrode pop and a run of spikes and an actual epileptic run of spikes. MRI, 3 Tesla scans, I think there are only 2 in the whole country. Seizure protocol is still very rare, and obviously the 3 Tesla MRIs are very expensive. And then the video EEG, which is available, but again rare, expensive, and very, very few people, maybe 2 or 3 in the country, who could actually decipher and diagnose them. Patients like this. If you see this, the video EEG, you can barely see anything. There's no change in EEG. Immediately afterwards, the EEG is perfectly normal. Immediately before that, the patient was in stage 2 sleep. Perfectly normal. So unless you know the semiology and you know what's going on out of sleep, this frontal lobe seizure would definitely be missed as a non-epileptic seizure, and this patient would probably be suffering from SUDEP and things like that. And then the video EEG, which is very, very important for seizures like this, where you just see this happening and you see this. And these are classical temporal lobe epilepsies. These are epilepsies which do very, very well with temporal lobectomies and epilepsy surgery. Over 80% success rate and seizure freedom in over 95%. And these are refractory epilepsies. These are epilepsies that are caused by mesial temporal sclerosis. And if these are not diagnosed and these are not picked up, and you do not have concomitant EEG with this to support your diagnosis and a good 3 Tesla MRI scan, these are patients that would be refractory to medications, that would have a horrible quality of life, and they just have the surgery, which would be much more cost effective. And we are in the process of doing a study on cost effectiveness of epilepsy surgery. So, drugs. There are many, over 30 anti-epileptic drugs available worldwide, and many other supporting drugs. But in Pakistan, we have a therapeutic frustration. The drugs we have, we are suffering. I mean, a patient is started on a medication, first line, say valproate at 250 milligrams twice a day, increased to 500 milligrams twice a day. They're still having seizures. Instead of increasing the dose and reaching an optimal therapeutic dose, another drug is added, and then another drug is added, and polypharmacy, and patient is refractory. Then multiple drugs, subtherapeutic doses, patient non-compliance. Obviously, when you're going to give them all those drugs, and they're expensive also, they'll be non-compliant. You have to stick to monotherapy, monotherapy, monotherapy. This was another study. We did a 2-year study, and we found that one of the main reasons for patients' compliance was polytherapy at cost. Lesser efficacy with non-branded drugs. Epilepsy is brand specific, but then by brand specific, I don't mean brand as in branded expensive, but the medicine that you have started, whether it is a local generic, and patient is seizure free, do not keep switching brands. Stick to that. Even though they could now afford, or they've got insurance and they could go on to a branded, more expensive medicine, do not do that if they are well controlled. Because every time you switch a brand, there is a chance of having a breakthrough seizure. Lack of awareness and compliance in drug shortages. This is what we saw in our 2 years follow-up on our patients. Epilepsy surgery, a little bit about epilepsy surgery that we have. It's FDA approved. There's the vagus nerve stimulation, there's surgical treatment, there's investigational, which we do have the deep brain stimulator. We are in the process of bringing the vagus nerve stimulator, and we do have surgical treatment. Okay, so this is the vagus nerve stimulator, and this is epilepsy surgery, 85% seizure-free rates. Resections, we do lesionectomies, we do lobectomies, and we do hemispherectomies. We have done disconnections, callosotomies, subpial crown sections, and augmentations. We have the deep brain stimulator. We are in the process of bringing the vagus nerve stimulator. The only problem with these is they are very expensive. So these are the surgery services available that we have here. Very few people are aware of the surgical option, vagus nerve stimulation as a treatment for epilepsy. There's a lot of surgery phobia, lack of phase 1 and phase 2 monitoring units. Devices are very costly, lack of expertise, motivation of both medical and surgical staff. So, for epilepsy training in Pakistan, we do an annual epilepsy Ninu fellowship in which about 30 neurologists from remote areas, psychiatrists and general practitioners or family physicians who deal with epilepsy on a regular basis are trained specifically on epilepsy. This is a 3-day intensive workshop, and national epilepsy guidelines with the help of the Pakistan Society of Neurology and NARF have been published as a guideline for family physicians and general practitioners to guide them in treating epilepsy. There is unfortunately no structured epilepsy training program available at this time. There is a proposal for epilepsy fellowship training program submitted and is pending approval by the CPSP. The way forward, we need structural epilepsy and EEG fellowship programs for postgraduate neurologists. We need structured epilepsy clinics, multi-specialty epilepsy care with trained case workers. As I had briefly mentioned due to time, that we need counseling, we need patient counseling. We don't want people going and aborting their unborn children because they have epilepsy. We don't want women being divorced because they have epilepsy. We don't want people being fired from jobs because they have epilepsy. We need an epileptologist, we need a psychiatrist, we need therapists and neurosurgeons and neurophysiology technologists for refractory patients so we can work together. We have to put a hold on drug shortages. Where Dr. Aisha was showing that drugs are available everywhere in the market, anti-epileptic drugs are almost 50% of the time short. The minute I get my patients controlled, the drug's gone out of them. So we really have to, we need a drug subsidy, and we are working with the government for cheaper drugs and anti-epileptic drug subsidy. Thank you very much.